afternoon, everyone, and welcome to today's HANYS Solutions Product and Part Showcase, tackling the challenges of onboarding a PQRS solution. Before we begin today's presentation, I do want to cover a few housekeeping items. Attendee telephone lines have been muted. Please submit all of your questions using Q&A and/or the chat tool to the upper right-hand side of your screen. We'll take all of your questions at the end of today's presentation. Today's web session is being recorded and will be emailed to the attendees along with a copy of the slides within the next several days. HANYS Solutions partnered with Spectrumetics to New York State eligible for professionals an OC certified solution to support them through the quality reporting process. Spectrumetics PQRS solution enables EPs and group practices to fulfill all requirements for PQRS payment, supporting EPs through the entire reporting process. I'd like to introduce today's faculty. This morning, joining us is Mary Ellen Crittenton, Senior Administrator of Quality and Patient Safety Officer for Greater Hudson Valley Health System and Orange Regional Medical Center. Loretta Willis, Senior Director of Quality and Research Initiatives at the Health Association of New York State, and Raj Lakhanpal, CEO, Spectrumetics. And Raj is also a member of the National HANYS Clinic and Business Intelligence Committee. The agenda is as follows. We will do an overview of the PQRS reporting for 2016, an introduction to the macro and MIPS. We'll then talk about Greater Hudson Valley Health System and the process that they followed in selecting and reporting. And we'll turn it over to Raj, who will talk a little bit about Spectrumetics solution and do a product demonstration. And at this time, I'm going to turn things over to Loretta Willis. Loretta, thanks for joining us this morning.
Very much, Terry, and good afternoon, everyone. Thanks very much for having me on this webinar today. I work in HANYS Quality Institute, which supports members in quality and patient safety. We provide tools and resources to HANYS members to support you and to improve your work on efficiency, effectiveness, and performance across many of the quality domains. Under the CMS Transforming Clinical Practice Initiative, HANYS is also providing some practice transformation and technical assistance coaching to several practices on Long Island. And our technical assistance includes maximizing PQRS and meaningful use reporting and education regarding the future requirements that are emerging today. Quality Institute as a whole works with providers to help them connect the dots and avoid as much duplication of effort as possible as it relates to all your reporting obligations. The data you're collecting and reporting for PQRS is very important because it can help drive performance across multiple programs as well as form a bridge for future reporting. Of course, you avoid a CMS payment adjustment for Medicare, but the same measures can also be used for quality improvement in your PCMH and advanced primary care programs and can help you perform well in DSRIP because of the focus on chronic conditions, efficiency, and readmissions. But provider reporting is changing, and CMS recently released the macro MIPS proposed rule for public comment. Actually, that was released in April. The final rule will likely be issued sometime in November. As part of our advocacy work, HANYS provided several comments to CMS regarding measure alignment and provider stakeholder input, among others. I'd like to see more providers, such as those on the line today, at the table and deciding what measures actually reflect the quality outcomes that providers are working so hard to achieve. Our comment letter is posted on the HANYS website for those of you who are interested in reviewing more detail, and I provide you with the resource link at the end of my presentation. MACRA stands for the Medicare Access and CHIP Reauthorization Act, and it was signed into law in April. The bill was passed in a bipartisan manner and repealed the very flawed sustainable growth formula, and it's replacing it with two tracks for physician payment, either the Merit-Based Incentive Payment Program, or MIPS, or incentive payments for participation in the most advanced alternative payment models, or APMs. The proposed rule is critical because its policies will change the way baseline Medicare physician payments are updated under MIPS. The result will be variable payment updates for physicians, either positive or negative, based on certain performance factors. Another track has also been established, as I mentioned, that could exempt physicians from MIPS and provide a bonus payment based on participation in APMs that meet certain standards. And I know that our speakers from Spectrum Medics will be speaking a little bit more about that later. MACRA also streamlined multiple physician quality programs under the new MIPS track, including, we're here to talk about today, PQRS, or the Value-Based Modifier, and Medicare Electronic Health Record, or HR, incentive program. The annual physician fee schedule payment updates mandated under MACRA. And as you can see, MACRA provides a 0.5% payment update from calendar years 2016 to 2020. On the update factor, MACRA provides additional payment adjustment tying to the value of services furnished by physicians and actually providers in general. MIPS eligible clinicians will see an upside, neutral, or downside adjustment based on their performance in 4 performance categories, starting from 4% and incrementally increase to 9% in 2022 and the subsequent years. In the other tract, qualifying APM participants will receive a 5% bonus in addition to the arrangement under their specific APM. Because MIPS combines aspects of the previous physician quality programs, penalties for the Medicare EHR incentive program, value-based modifier, and PQRS will sunset in 2019. Just to give you some highlight, and again, other speakers will also talk about this, MIPS reporting encompasses 4 separate categories that you see here on this slide, and many of the proposed measures are from the PQRS program that you're familiar with today, and there may be opportunity for a thoughtful transition from one program to the next. So in other words, providers have an opportunity for some of the measures they have chosen to report on under PQRS to do the same under MIPS. Medicare Meaningful Use transition to the Advanced Care Information category you also see on your screen no longer combine the EHR reporting standards with quality metrics. So all the quality measures will be housed in either the quality category or the clinical process improvement quality. Under the quality domain, providers are expected to submit 6 measures, including one of which is called a cross-cutting measure, and that includes things like advanced care planning, Medicare patient reconciliation, chronic condition management, and so on. Is important because the first performance period for MIPS is next year, the way it stands today. There has been some recent outcry from providers as well as the political community to potentially delay the onset, but the way it stands today, the timeline on this slide is currently proposed. The performance year would be 2017. Payment adjustments would actually begin in 2019. This is a busy slide and not one easily read without making a little larger, but I put several links to resources here, and I want to point out in particular the second bullet, which I've noted that this is the proposed rule, and on page 836, because it is 1,000 pages, there's something I think you might be very interested in, and it's the proposed MIPS specialty measure sets. And what they've done is categorized the measures that would likely apply and be most appropriate for different specialties. And general medicine and internal med, as well as specialties, are included in these sets. And it may be of interest and a little less overwhelming for you to view the available measures that way. There have been under MIPS some adjustments made to some of the PQR measures. Measures also worth noting. And with that, I'll pass the presentation to Mary Ellen Crittenden, and I'm very happy to answer any questions at the end of the program.
Good morning, everybody. I am Mary Ellen Crittenden, Senior Director of Quality and Patient Safety Officer for the Greater Hudson Valley Health System. I'm also joined by Katie Hahn, who is our Quality Data Analyst, who's very involved in this whole project. So we're asked by HANYS and Spectromedics to share our story about just really how we got into the PQRS reporting process last year. First, just a little bit on Greater Hudson Valley Health System. We are located in the Mid-Hudson Valley, just a little bit north of New York City, south of Albany. We are a not-for-profit organization. Our system is comprised of 2 acute care hospitals, one located in Middletown in Orange County and the other in Sullivan County in Harris, New York. We have a critical access hospital in a little bit more rural area in the top of Sullivan County. We also have multiple outpatient primary care and specialty sites across Orange and Sullivan counties. So MC is really the mothership hospital. We have 383 beds. We're very lucky to have a brand new facility that was built back in 2011. And we're also near completion of a new adjacent physician office building and new cancer center. So it's pretty exciting. We have a lot going on. We're a new teaching hospital now with an affiliation with Terrell College in New York City, and now have medical education programs including internal medicine, surgery, ED, family medicine, and psychiatry. What also is new, and we're pretty proud of this, is what we call our Triple Crown Award. We recently achieved the Magnet designation just a few months ago, and we also received a state Silver Baldrige Award, and then recently the HIM 7 achievement or recognition for use of our medical records. So we like to call that the Triple Crown. Our Regional Hospital has 218 beds located in Harris. It also has a nursing facility wing, and we have our 15-bed critical access hospital. What's also very new to us is a growing Greater Hudson Valley Health System medical group. Up about a year or two ago, we really only employed a few physicians and providers. So really, we have expanded our primary care sites, our specialty sites across the 2 counties. We have added hospitalists, critical care, intensiveness, trauma, cardiology, and many more. It's really important to note as we as we look at this whole sector of employed physicians that really were not on our quality radar. So PQRS, so again, just as recently as late 2014, it wasn't on our radar, and it was really just through general research and reading and keeping up with the CMS programs and regulations and coming across PQRS. I was familiar with the program, but really historically had not been involved in it because we historically worked on the inpatient side. Looking more into it, I realized that we did, in fact, have to report this data. And what's interesting is that really no one was really familiar with this program, especially even many of our physicians. So it was about gathering the data, mostly from the CMS website, listening to the available webinars, and literally just following the step that CMS outlines, the very basic steps. You know, number one, identify the eligible providers. You know, you would think that this would be easy, but it wasn't. When we look at getting an accurate list of providers, you know, who's billing Medicare Part B, looking at inpatient, the outpatient, you know, looking at the different physician, PAs, nurse practitioners, anesthesia, contracted providers, locums, et cetera. And under the three different TINs, the tax ID sectors, it really, and then where are they billing? It was challenging even just to come up with an accurate list, but we finally did. And it was really about looking at, well, how do we report this data? What option should we go with? Do we go with registry? Do we go with the web interface? Which kind of reminded me of the old CART tool from many, many years ago for inpatient quality reporting. So I thought we better stay away from that. You know, do a direct EHR or claims. In the end, we decided to go through Spectrumatics mostly because really, you know, having someone really walk us and guide us through this whole process and really their hand. So this, I think, the biggest challenge was there was a lot of unknowns because this was new to us. It was going into unknown territory. You know, do we have the resources? Do we have the skill sets with respect to mining the data and accurately submitting this data? You know, we are not a very large quality department. I think like many hospitals, our resources are limited with, you know, many things on our plates. We even considered, you know, all the different scenarios, such as maybe not even reporting, you know, and what that financial impact might be. But we determined that they were in fact significant enough to warrant the reporting. Also, really, reporting is the right thing to do. You know, got to get your feet in at some point. So it's about really reporting data, using the data, and really improving care from that. So our objectives, I'm going into this really, it was about at least just getting the reporting done. You know, getting our baseline data, just figuring out how do we accurately submit it to CMS. Going in that the data probably was not going to be great, especially, you know, in how it was being captured. But again, it was a baseline. We also obviously wanted to create an infrastructure, you know, so that we can really use this data and improve our care processes. Ultimately, you know, create reports by site, by provider, and use the data to really make workflow changes and improve care. So from the very beginning, we engaged our key medical staff nurse. I think that's really, really important to get them in right up front, and we kind of stumbled through this together. Ultimately, we decided to, you know, to go with, again, with Spectra to really help because we realized we don't have the resources at this point in time. So a piece in this program is selecting the right measures. We wanted to make sure that the measures aligned with other programs, such as meaningful use, electronic clinical quality measures, with our primary care medical home initiative, We're actually one of 2 EPIC hospitals last year that successfully submitted the ECQMs, which was a first and a big challenge as well, separate project. The measures, we wanted to make sure that they were consistent with our internal priorities. I think most importantly, we wanted to make sure that they were meaningful to our providers as well as important for our patients. So I'm going to hand the phone over to Katie at this point, our data analyst, who really took the lead in drilling down on the measures and worked very closely with Spectra and getting us to where we needed to be.
Everyone. So to get started in this process, we had to create a multidisciplinary committee to work towards the submission. So the committee had to review the list of 135 measures and choose 22 that were general enough to reach all eligible providers across the specialties within the 3 domains. And the measures that we selected from were effective clinical care, communication and care coordination, and the community and population health. And then Dr. Medics ran a data analysis on the claims that they received from us. Realized that out of the 22 measures, only 15 showed patients with a denominator and no patients within the numerator. Then at this point, we realized that our EHR wasn't mapped to G codes, which is required for the claims-based reporting, and those are the quality indicators that CMS identifies with for Medicare billing. Mapping measure points is really complicated and time-consuming. We were faced with the challenge of manual abstraction for our enumerators. Which measures we wanted to report on by eliminating measures that were complex and of high volume, but still were over 33,000 encounters that needed to be reviewed within the 9 measures that were left. It's the MEC measure 130. It had 8,400 encounters alone just to sort through and look at. And since we had limited staff for the manual abstractions, we divvied up the workload amongst 3 of us, our quality department, and the IT staff members were able to help out as well. Each of us put in about 1,000 hours or more for manual abstractions. Spectra Medics, though, was able to guide us through this process and answered any questions we had, even if it felt like there were 15 a day. They also sent us the files for each measure, which was helpful reference to read and read again and then debate about what was good and what wasn't. But during the process, we recognized opportunities for improvement in our staff workflows. For example, measure 236, controlling high blood pressure, we identified that one of our specialty groups didn't perform blood pressures during the rooming process. So we had to make changes to help improve our future outcomes, for 2016 reporting. And when I identified the numerators, I worked with Spectra Medics on uploading the files into the portal, which was really easy. And they were able to provide us with an analysis of our measure performances, which I don't think we did too bad, but it wasn't the greatest, for our first time ago. So that's it. Good.
So this is just a visual of the overall project and the infrastructure required. Essentially, it shows, where we're pulling data from, the different TINs, and all the different sites, inpatient, outpatient sites. Luckily, all our sites throughout the system are on EPIC. Although we were transitioning a few of the sites during 2015, so that kind of complicated things some. Essentially, it's taking the billing files from the different areas, calculating the measures, and then uploading the data to Spectra Med portal. So we successfully submitted the 9 measures. So we achieved, the basic goal. In the end, we identified we had a lot of opportunities in these measures, but we achieved baseline and now continue to work on improving the workflows to improve the scores. So lessons learned. I think that the most important lesson for me, the way I've worked in quality for quite a number of years, is that quality has really evolved into something new these days. It's not like it used to be. It's a very different it's a whole different team as well. And we need to really work hand in glove with our IT partners, with our finance partners. And luckily, we have an amazing team. We work so well with them. It's really, really worked out nicely. I think it's also important to ensure that the roles are clearly defined because, you know, you come up with, well, what does quality now own or do versus what does IT do in this whole new electronic world. And also making sure that there is a definite plan that, you know, again, all the folks, all the different players know exactly what to do, what needs to be done, and over time frames in order to ensure that we meet the deadlines. Another important lesson is that it's really important to align programs and measures. You know, many of the programs have the same measures, but maybe the specifications are a little bit different. So we heard a suggestion to use the primary care medical home as a guide, kind of use that as your central basis. And you go down that path, that will kind of get you through many of the regulations coming down the line. So that's basically what we're doing. Another thing that we identified was that it seems to work for us to focus on conditions rather than programs. So when we talk about improvement in workflows at the different inpatient and outpatient sites, we found the condition of asthma or diabetes versus PQRS. So we're in the very early stages of all of this. You know, I think we have a long way to go in working to build the capacity to really use this data well and, you know, track it and get it to physicians in a meaningful manner. But, you know, we're beginning in our way. I am going to turn it back to Terry.
Great so much, Mary Ellen. That was really insightful information. So we have a survey question. We'd appreciate it if everybody would take a few minutes to answer it. The first question, or the only question we have is, what is your biggest challenge to reporting PQRS measures in 2016? And if you had and select one of the following three, identifying appropriate PQRS measures to calculate based on specialty or clinical practice, successfully extracting data from EHRs and validating data for PQRS reporting, or the ability to track, compare, and improve measure performance. We've got just a few more minutes remaining, or a few more seconds, I'm sorry. If you could just submit your answers. Okay, well, let's close the poll. It looks like the majority of people are, I don't know, it's kind of split between A and C, identifying the appropriate measures or the ability to track. So interesting. Thank you so much for participating in the panel, or in the poll. I apologize for that. And turn things, Lockenball, the CEO of Spectromedics. As soon as I can get back, Raj.
You have the control.
I understand that. I just was being delayed because of the polling question. And there you go.
Thank you. So, everyone, my name is Raj Lockenball, and it's a pleasure to present to all of you. I'm the founder and the CEO of Spectromedics. Joining me is my colleague, another Raj Ardeshna, who's going to be answering all your difficult questions. He's the business analyst on PQRS.
Hi, everyone. Good afternoon.
So I think Mary Ellen and Katie had done a wonderful job in presenting the use case. So I'll keep my presentation brief. Spectromedics, we're about 6 years old as a company, and our PQRS solution, we have a library of close to 250 PQ measures. As Mary Ellen had said that they're going by disease, we have 23 measure groups. So I'll touch on that. during my demo. And, VBPM is important this year, so we also have VBPM cost and outcome measures and CMS submission. We can collect data, and we do collect data in different formats. Collected through billing format, that's how we used for them. We can also collect data directly from the EHR in different formats. One is a CCDA format. You can upload files to us, or you can do a custom web interface, which is called Smart Web Forms. And then again, trying to respond to tailoring it to your poll questions. We also have a fairly significant capability for you to track, compare, and improve measure performance. And also, as I'll touch on that in a subsequent slide, to how to help you select the PQRS measures. But within the capability to help you improve PQRS measures, we have benchmarks. There's a national benchmark, and then there's a benchmark that you can select for your EPs, help you with remediating data gaps, and then tracking the measure analytics. I had already touched on MIPS very briefly. Penalties. So PQRS is all about VBPM and MIPS. Really, if you look at it, and MIPS kicks off next year from 2017. This year we have VBPM, as Loretta had mentioned. PQRS, VBPM, and MU are going to be all rolled into MIPS from next year. So the fees for MIPS are 4% for not reporting PQRS in 17, but applicable in 2019, and minus 4% for not reporting. So you can get up to a 4% incentive or up to a 4% penalty. So the delta is 8% for 2017 into 2019, going to 18%, 9% plus 9% in 2022. And budget neutral program for CMS, the top 25% can get up to a 3x adjustment. It's a complicated formula, but there are significant incentives for reporting well. And the well I mean is there are four components. Again, as Loretta had mentioned, you have to report PQRS for MIPS, and the weightage of that is 50%. Advancing care information is the weightage is 25%. That'd be the old meaningful use. Clinical practice improvement is 15%, and it'll be around whether adopted a patient-centered medical home, you connect to an HIE, are you interoperable as a group? So, and the cost component is 10%. But keep in mind, cost will keep on increasing as MIPS advances. But I think the important take-home from this message is, from this slide is that you have to report PQRS to be successful for MIPS. So partnered with HANYS about a year and a quarter back, and you heard from Mary Ellen from Hudson Valley Hospital Health System. Then we submitted successfully for Auburn as well last year. We're currently submitting for Cuba. And Mount Sinai, we're part of we're collecting calculating data for close to 85 PQRS measures for internal reporting today, to make them more efficient as they go into clinical integrated networks and other initiatives. So that's a very novel initiative as well. I'm going to give a brief demo of our portal, of our solution. And as you look at the solution, you will see different roles. There is an executive role. The executive has a view of the entire system, how it's doing for the PQRS reporting. It does not have, that role does not have PHI. The analyst role, on the other hand, has access to PHI. The analyst analyze patient-level data, can drill down to address any gaps in care, drill down to address any rejections. And the extra is also the submitter role, which is on the left side here. So the analyst, after reviewing the data, can also submit. And then have a provider role where they can compare performance with their peers. So I'm gonna go down to so I want to check that you can see my screen.
Can, Raj.
Okay, so here's the physician executive, or the executive role. That doesn't need to be the physician. The executive role, no PHI, but can look at all the EPs that are here. And also, this is calendar year 2016. These are the domains. So as Mary Ellen had said, you need to report 3 domains, 9 measures from 3 domains. So here, the various domains are here, and these are the providers. So in this, we'll take the example of Dr. Austin, who is EP, and looking at how she's performing with various domains. Then we can click down on her, and we'll pick a diabetes measure, HbA1c, poor control, and then domains are at the top. And then, Mary Ellen had mentioned, we selected, they gave us data on 22 measures. We said, let's pick 15 measures because you have data on them, and then let's see how you're performing on them. So here we're looking at diabetes. We have different benchmarks for the improved quality. So this is the national benchmark, and then you have a target benchmark. You institution, or if you have various, you may be part of a CIN, clinically integrated network, or you may be part of various pay-for-performance programs where you have to report on PQRS measures. So say you've put in a target here, and then you can track that on a monthly basis if required or as required. Then we go down further, and this is the individual reporting as an individual EP. I'll show you reporting as a group. So here we're looking at how, as an individual EP, you will report for Dr. Austin. And we're looking at how they're training, the details here. And then here, you're looking at how Dr. Austin is comparing to her peers. Other EPs, how is she comparing? And this, each one of these rectangles we call a KPI, key performance indicator. So this is how we could select any other KPI that's important to you as an institute. A group, if you decide to report as a group, then you will not see individual doctors or individual EPs, eligible professionals. So here you're looking at the different measures. And this remains the same. You've got the same benchmarks. Now you're collectively looking at a group, how the group is performing, and you look and how the group is trending. And these could be different key performance indicators for the group. Log out of the executive role, and we'll now go into the informaticist or the analyst role. And this, again, the first one is reporting as an individual. EP, Dr. Austin again. This is the analyst, has greater detail about the measures. The analyst can then drill down. And this is an important screen. This is a good screen. Now, based on the data we've received, in Greater Hudson's case, Mary Ellen's case, gave us claims file, we had missing. And this is, in all likelihood, they did not apply G codes to that data. So we went back to them and said, could you please apply the G codes and send us the file back? If you're, let's say, reporting with clinical data, this is a very good, this can help you with data governance. So data was missing, there could be reasons. Data was entered, or the workflow did not allow it to be captured, or data governance needs improvement. So all those things could be remediated by looking at these areas. So you could improve your workflow. For example, this we missing. This is HbA1c because the missions ordered were not entered, or laboratory data was not available, and that could be all improved. So this is, again, this was reporting individually. Same thing here. Analysts can go into a GPRO role, reporting role. Same things. and you'll have the same, you won't see, it will be at a group level. Now, also, the analyst could, after the analyst is able to review everything and improve everything, at the end, they will select measures, they will pick different measures and say, I want to report on these measures, and go down and click reporting. And we'll get the measures they've selected, and then Spectrometrics will take those results, form files, and then I'm ready to submit to CMS. I have to show you, let me go back here. So this is based on PQRS measures. If you want to report them as a disease measure group, different from a GPRO or a group reporting, as Mary Ellen was saying, look, we are not focusing on PQRS measures, we're focusing on various conditions, diabetes, asthma. So this is as a diabetes measure group. Measures, and you can only report on this as an EP, eligible professional, not as a group. But as each EP, you don't need to report on them 3 domains. You can only report on the 6 measures, and that qualifies for your reporting. But allow you now. The other thing is you're saying, look, we're reporting, we're tracking, but my doctors need, or my not doctors again. I'm sorry. My EPs need help, guidance in improving performance for PQRS. Can you help them improve performance by providing them gaps in care? So as EP, I'm saying, okay, I know I'm falling behind on my HbA1c measure. Can you find all the patients that did not have the HbA1cs done, or the HbA1c levels are high? So this is what this is. This shows them here are gaps in care that you need to improve to be able to improve your reporting or improve your performance and analytics. So I'm done with the demo. I'm going to go back to the presentation. Okay, great. The way we manage the process, and I think Mary Ellen and Katie had mentioned about this or talked in detail about it, we do an assessment first. Assessment allows you, especially if you're new to PQRS, it allows you to identify multiple things. We help you with data gaps. We help with any data governance issues. We help you select the measures. And very importantly, we also help you align those measures to other programs you may be doing. Mary had said around patient-centered medical home initiatives. I think it's also very important right now to align with MIPS as well, so that as our team understands the MIPS measures, so they will align with those measures, so that you know, ready for next year as well. So it takes some time. We help you remediate, or you will remediate on your own. Once we are comfortable that your data is in a good enough quality for us to begin implementation, we begin implementation, training, review, and submission, and then the entire process takes about 8 weeks, 8 to 10 weeks. Now, if you have data gaps, you have challenges there, it could take much longer. At times, taken 12 to 16 weeks. So I highly recommend that you work on this journey as soon as possible. Don't wait till the end, because it will face challenges then. And we will together, if you select us, we will together face challenges. So 8 to factor to 12 weeks. If there are no issues, catch longer. If there are issues with data, you need to improve workflows and work on those things. So just a summary of the Spectrometrics total solution. We calculate a very significant number of measures. We have a library of measures. We can collect data in different formats, support multiple methods to report for PQRS, whether you want to do it from claims or billing data or clinical data. We are certified all the ECQMs as they pertain to PQRS. We understand MIPS very well, and so that you can report. You can be prepared for the reporting part for MIPS. On the PQRS side, we support multiple TINs, and then support hospital-based EPs not documenting in hospital EHRs. I think very importantly, as we go, I'm also honored to serve on the HANYS Clinical and BI Intelligence Committee. So we privy to information as it comes at the national level. So as MIPS evolves, improving PQRS measure performance is also very, very important. So we enable you to do that too. And for your time, Tara, I'm done with my presentation. We can open it up for questions.
Okay, great. Thanks, Raj, and thanks, Mary Ellen and Loretta. That was a great presentation by all of you. I do want to remind everyone that we are taking questions. If you could submit those using the Q&A or the chat tool, we'll ask them. I just want to start with some of the questions we had during the presentation. The first question, will the Spectromedics team help with measure selection for individual EP reporting?
This is the other Raj from Spectromedics. Again, I'm the business analyst working primarily with PQRS Solution, and so I'll be answering some of the more quality and related questions today. But yes, absolutely, we will be ones to work with your institution to come up with the measure selections going forward. And Raj briefly spoke about our PQRS assessment, and that's a large component of that assessment, figuring out what measures are applicable to your EPs and the report option that that you've chosen to go across.
Great, thank you. Another question, who will submit files to CMS, Spectromedics or the hospital or client?
It will also be us. As you could have seen in our demo, we have a role in the portal that we give you that allows an analyst or a submitter to choose the measure that they feel comfortable with. We will then receive an update that has been selected, and we will go ahead, create the necessary files in XML, and send those directly to CMS on the client's behalf.
Okay, thank you. Staff involvement is required in the solution implementation and management. I'm meaning that's staff from the provider.
You to take the question, Marilyn?
Yeah, go ahead, Mary Ellen.
Well, I think it depends where you are in the reporting process. So the initial work, the 8 weeks or so where we were really drilling down on the measures and trying to look at those gaps and identify the measures. Obviously, Katie in quality as well as our IT folks worked a bit on that piece. And then it really came down to the manual abstraction that was very labor intensive for a few weeks where, we had to pull bodies as we had together to drill down on and making sure that the data was as accurate as possible, and that, was the manual abstraction. So as we move forward with the mapping and with the documentation, workflows and the documentation within the medical record, it's less resource intensive because, we can pull that data from, discrete areas.
Thanks, Marilyn. Does Spectromedics support the group reporting for ACOs?
Yeah, we do. That is another solution that we have. We do support group reporting, or the GPRO option for ACOs. Okay.
We have multiple TINs, multiple disparate databases, multiple inpatient and outpatient locations, multiple platforms. What's a suggestion for staffing for an institution with 150-plus inpatient clinicians and 60-plus outpatient clinicians, and in what roles?
Take that question. So from our perspective, I think it's still evolving. As we are working with these different programs, the PQRS, the ECQMs, the meaningful use, the MIPS, it's really evolving the team, and because I think we have a similar staffing, 150 providers in patient, outpatient, multiple settings. Will make a difference if you're all on the same EMR, I think. That's certainly an advantage that we have. But it's really evolving at this point. We are creating new roles. We just created a new quality role for our medical group. So it's, it's really a moving target, I think, at this point.
I'm sorry, Loretta, do you have anything to add to that? And you've seen among the members?
I'm sorry, not at this point, Terry, but thank you.
Okay. And Raj?
Rod Square.
Yeah.
I thought the question was directed to Terry Ellen,
Okay.
Staffing. But if they need our guidance in any way, we'll be very happy to just consult with them, just guide them on what get done. It needs a little bit more information. We have disparate EMRs, disparate TINs, so for us to really look at, it'll be to know if all the EPs are on the EMR, do they have EPs that don't have an EMR yet. I think this needs a little bit more thought. Would be very happy to have a follow-on conversation about it.
Okay, super. Thank you. And the last question I've got that came in, what's the pricing model?
We have, the way we price it is we have a pricing model. We do a initial assessment, a readiness assessment, and we found that most clients really valued that. And there is an implementation fee, and then we have a per EP fee. It really is scaled down depending on the number of EPs. So the higher the number of EPs, the lower the per EP fee. It's a little complicated there because, some clients have opted to say, I just want to report once. That's all I want to do. Another clients have now said, no, I want to do a monthly, I'll give you a monthly feed, and I want to really track the performance of my EPs, and I want to improve it for various value-based initiatives. There's a, different price for that. Mark Bryant, or there's on the screen you have spectromedics.com, or you reach out to any of us at Spectromedics. We'd be happy to discuss the pricing.
Okay, great. Well, thanks, everyone. That's it for the questions. So I would like to just turn it back to our presenters to see if there's anything that they would like to leave audience with. Mary Ellen, anything you want to share with the audience before we sign off today?
I think just that, first time through in this program and, all the other new programs coming down the line, it's challenging, but, I think we're beginning to get it, and it's really begin to see how many of the programs are aligning and going down the same path. It really has impacted what we do in quality. So the thing regarding staffing and roles, they're changing, and I think that it's important that we change, to meet the skill sets and where we're going in this whole new electronic world. So I think if anybody has any questions or wants to reach out to us, we're happy to to speak with anyone as well.
Thanks, Mary Ellen. Lorraine, anything you want to share with the audience before we sign off on behalf of HANYS?
Thanks, Terry. I think there's a couple of points that I just want to stress. And number one is, I was happy to hear Spectrumetics is working on, transition kind of plan to MIPS, because I think it's really important to recognize that that's right around the corner. And that even though the first performance year is 2017, pros don't actually begin reporting until 2018. And another point is, even though a lot of the PQRS measures are the same, there's also a significant number that have been changed. Just to give you an example, under the proposed rule, there's 18 new measures proposed, there's 29 proposed for removal, and there's 70 existing PQRS measures that they're asking for some significant change. So something to be mindful of as you're picking what you do today under PQRS, but preparing for the future.
Thank you. And Raj, anything you want to leave our audience with before we say good afternoon?
Not much. Just thank you for your time. Thank you for attending the webinar. And also, please, we're partners with HANYS. If you have any questions, reach out to them or reach out to us. We'll be happy to help, even if you're not a client. So thank you again. That's it.
Well, on behalf of HANYS Solutions, I want to thank everyone for joining us today and remind you all that we did record today's session. And I'll be sending an email to everyone by the end of the week, so look for something coming from me every August that will include the link to the webinar, a slide deck, and also I'm going to share with you the case study that Greater Hudson Valley and Spectrumetics put there on the experience that had selecting a partner and submitting data. It's a great piece and well worth the read. So thanks everybody again. I really appreciate your participation. Have a wonderful afternoon, and give us a ring if you have any questions. Good afternoon. Bye-bye.